Check if it is online now. Yeah, on YouTube and Facebook. Yeah, it should be there. Good afternoon, everyone. Welcome back once again after lunch for the second session of the symposium, research presentations. To lead this session, I would like to invite Dr. Alison Nicholson to chair the second session research presentations. Dr. Alison, you able to hear me?
Hey, good afternoon.
Good afternoon, Dr. Alison Nicholson. Thank you very much for joining us.
Thank you. Thank you for having me.
Thank you. Ladies and gentlemen, Dr. Alison Nicholson is a medical microbiologist from Jamaica. She is a senior lecturer in Department of Microbiology at the University of the West Indies, Mona campus, Jamaica, and a consultant medical microbiologist to the University Hospital of the West Indies, Jamaica. She is also chair of Infection Control Committee at UHWI and recently developed a postgraduate diploma program in infection prevention and control in healthcare environment. Dr. Nicholson is specially interested in antimicrobial resistance and control and prevention. And also she is co-founder of our organization, Caribbean Association of Clinical Microbiologists, and is very proud of its development and impact on the region and beyond. We are glad to have Dr. Alison Nicholson with us today, this afternoon, to chair this research presentation session. Dr. Nicholson, now floor is yours. Thank you very much.
Hi, good afternoon, everyone. Thank you so much for this invitation. I'm really pleased to have been invited to function in this way. And I want to join my colleagues by extending a warm welcome to everyone on this forum, to the CACM Symposium, and in particular to this session 2. I'm sure you all agree that the presentations thus far have been excellent, and we look forward to more of the same in this session. I don't think I can let this opportunity pass without commending my CACM colleagues here in Trinidad for the tremendous amount of work that has been done to bring this day to pass. So I want to recognize this, and I want to register sincere appreciation. Now to the matter at hand. In this session, we will have a chance to hear about some of the research being done in the region. So I will introduce our first presenter, whose name is Stephen Stone. Just 1 second, and I will come with an introduction for Mr. Stone. Okay, so Stephen Stone is a postgraduate student here at the University of the West Indies, the Mona campus. Stephen recently successfully passed his upgrade exam from the MSc in biomedical research, and he's currently pursuing his PhD in molecular biology. Congrats, Mr. Stone. He has interests in antimicrobial resistance and viral therapy. Stephen is a previous member of the Dean's List and an honor student, and he continues to work on uropathogenic E. coli and Klebsiella pneumoniae, exploring the mechanisms of antimicrobial resistance seen, as well as the impact of 2 component systems on antimicrobial resistance. Of interest Stephen is a member of the American Society for Microbiology, and he is now a student member of the Caribbean Association of Clinical Microbiologists. Welcome, Stephen. We look forward to hearing from you.
Chair, my apologies. Can I have a few seconds, please? Well, my apologies. Before Steve, you please start sharing your screen. Before just few seconds, I need to inform something. Dr. Nicholson, you are in the panelist, right? Which I gave. I was told that there were some issues. I hope that is okay now. Dr. Nicholson, can you confirm me everything is okay? All right. So, dear all,
sorry, Dr. Chandrasekhar?
Yes, Doc. I was told that there were some issues. Now you are okay, right? I mean, with your connection?
Yes, I'm going to ask you for 2 more minutes, just 2 more minutes, and I will get back to you. Can you do that?
Yeah, I will do that. No problem. Thank you.
Thank you.
Before Mr. Stone continues, I would like to take this opportunity to invite Dr. Glendy and Dr. Arvind Kurade to be judges for these initial four presentations. Thank you very much. Mrs. Stone, now floor is yours. You can continue.
Right, thank you and good afternoon, everyone. Thank you, Dr. Nicholson, for the introduction. If I'm hoping everyone can see the screen and hear me clearly.
Yes, we can.
All right, wonderful. So I'll go ahead and begin. Good afternoon again, everybody. My name is Stephen Stone, and I will be presenting on extended spectrum beta-lactamase surveillance in gram-negative uropathogens in patients at a tertiary care hospital in Jamaica. So for the introduction, the Center for Disease and Control reported in 2019 that 2.8 million people get infected in the United States by antimicrobial resistant bacteria, causing over 35,000 deaths annually. Many of these infections are nosocomial, including urinary tract infections that account for up to 35% of infections. Etiological agents of UTIs include gram-negative bacteria such as E. coli and K. pneumoniae. And these bacteria actually fall under the family Enterobacteriaceae and have been placed under heavy investigation by the World Health Organization through the ESCAPE program due to an increased display of multi-drug resistance. So we also have what's known as beta-lactams. Now, beta-lactams, specifically third-generation cephalosporins, are commonly empiric therapeutic agents against gram-negative uropathogens. These antibiotics work by interfering with the process of bacterial cell wall synthesis by binding and inhibiting the penicillin binding proteins, causing cell lysis and death. And here we just see to the side 2 antibiotics that have the beta-lactam ring. So then we have beta-lactamases such as ESBLs. Now, beta-lactamases have the ability to hydrolyze the beta-lactam ring of beta-lactam antibiotics, such as Kefems and Penams, and ESBL is one of those classes. Now, ESBL-producing bacteria are resistant to Kefems, such as ceftazidime, and monobactams, such as aztreonam, but are susceptible to carbapenems like meropenem. When ESBLs are detected, nitrofurantoin, Bactrim, and carbapenems are usually the drug of choice for antimicrobial therapy. So we do have common ESBLs that are known, such as TEM, SHV, and CTXM. We have lesser known types, such as VEB and PER, and these are normally named by the bacteria that they may have been reported in or the place. So ESBLs, they've been detected in bacterial isolates from over 1.5 billion people worldwide, and the spread of ESBL genes have been observed globally. Locally in 2004, 18.2% of Klebsiella pneumoniae isolates from hospital patients in Jamaica were found to be ESBL producers. In 2013, 17% of fluoroquinolone-resistant uropathogenic E. coli isolates studied were found to be ESBL producers. A pilot study conducted in 2018 actually found 50% and 62.5% of ESBL producing E. coli and K. pneumoniae isolates respectively amongst complicated UTI patients. Regionally, a study was done in 2008 that reported a respective rate of 15.2% and 9.3% ESBL production in K. pneumoniae and E. coli isolates respectively, collected over a 3-year period in Trinidad and Tobago. In 2019, random phenotypic screening of isolates from the following countries listed below showed a high or concerning level of ESBL prevalence, at 31.5% resistant to ceftriaxone. So here we just have a diagram showing worldwide distribution of ESBL producers. Green suggests less than 10%, yellow goes up to 25%, orange up to 50%, and red over 50% ESBL rates. So the current trend in the prevalence of ESBL seen worldwide is concerning, as the beta-lactam antibiotics are the main treatment methods for non-severe UTIs. Continued surveillance of ESBL presence in hospitals allow medical professionals to have updated data that may aid in patient treatment. So the objectives of the study wanted to retrieve archived gram-negative uropathogens and their susceptibility data from January to March 2020, to create an antibiogram based on those collected uropathogens, to phenotypically and genotypically screen for ESBL producing organisms and their genes using the double-disc synergy test and multiplex PCR respectively, and to determine any correlation between the prevalence of these AMR genes and their expression within the patient population through demographic and clinical data. So for sample collection, it was determined by sample calculations that a minimum sample size of 73 isolates would be suitable for a precision of 5% for the study. We wanted to ensure that specimens that do not show significant bacterial growth were excluded. We wanted to make sure that all uropathogens that were suggestive of ESBL production were included. And also samples were collected from all clinical sites at the University Hospital of the West Indies Microbiology Department. So for isolate collection, the collected samples were subjected to routine microbiological testing during the study period to identify the gram-negative bacteria and to determine antibiotic susceptibility. Isolates were inoculated on blood and McConkey agar at 35 degrees Celsius for about 18 to 24 hours to differentiate bacterial species and genera. The isolates that displayed significant growth were then analyzed and stored in glycerol at -80 degrees Celsius for further characterization. We ensured that non-duplicate isolates per antibiotic-resistant phenotype per patient were included in the study. So for the double-disc synergy test, ESBL presence was detected using this method. A disc of amoxicillin clavulanate along with 2 to 4 cephalosporins were used. The isolates were placed on Mueller-Hinton agar according to CLSI guidelines, and the discs were placed 15 to 20 millimeters apart with the amoxicillin clavulanate disc at the center. If there was any distortion or increase in the zone towards the amoxicillin clavulanate disc, it was considered positive. And here we just have a positive result that showed the distortion between one of the cephalosporins and the amoxicillin disc, and the negative does not show this distortion. So then for genotypic detection, we start with DNA extraction. So bacterial genomic DNA was extracted via the boiling method. Isolates that tested positive for ESBL production were added to test tubes containing 1 ml of distilled water and boiled for 15 minutes in a water bath, followed by 5 minutes of centrifugation at 1000 RPM. And the remaining supernatant served as the DNA template for PCR using gene-specific primers. So we went on to do multiplex PCR using RedTac ReadyMix Master Mix, and we followed the ESBL parameters seen here. Here we just have a table showing the 3 ESBL enzymes that we were searching for or screening for, TEM, SHV, and CTXM. We have the sequences and the expected amplicon size for the genes. The study commenced after approval from the Mona Campus Research Ethics Committee and was deemed minimal risk since the archived bacterial isolates and the identified clinical data was used. Data collection sheets were secured in the Department of Microbiology, and collected samples were kept according to standard laboratory protocol. The project was mainly descriptive. All data collected was compared against each other, looking at prevalence from a specific bacteria, gene that produced the enzymes, and the demographics of where the isolates were obtained from. So samples were obtained from 80 patients that fell under the inclusion criteria for the study, from which 83 unique bacteria were identified and stored. However, due to unforeseen circumstances, only 64 isolates from 61 patients were able to be processed for further phenotypic and molecular testing. This created a 5.6 margin of error for the true population. So multi-drug resistant bacteria were identified in patients aging 1 month to 84 years, with 60% of them being over the age of 45. There's a high frequency of male patients harboring MDR bacteria. However, female patients were observed to have a higher prevalence of UTIs overall. Majority of the patients reside in St. Andrew, with other patients from parishes such as St. Catherine, St. Mary, and St. Anne. And some patients were also diagnosed with comorbidities such as diabetes and hypertension. Here we just have a chart showing the distribution of the bacterial species found, the main ones being E. coli as the predominant, followed by Klebsiella pneumoniae. Here we have a chart showing the percentage antimicrobial susceptibility amongst the bacterial population, both overall and for the ESBLs. And we see that amikacin and meropenem were the most effective, with ampicillin being the least effective. Here we also have the results of the double dyssynergy test. Only E. coli and Klebsiella were positive, and we had about 18 isolates in total. So those 18 isolates that were phenotypically positive, 16 of those were genotypically positive. We found 18 ESBL amplicons constituting BLA-SHV and BLA-CTXM, with 2 isolates harboring both SHV and CTXM genes. However, no TEM was detected. Here we just have the SHV amplicon being shown on the left and the CTXM amplicon being shown on the right. So as projected, a majority of the UTI samples originated from female patients. However, male patients had a higher percentage of ESBL-producing bacteria. E. coli was the predominant ear pathogen observed. However, K. pneumoniae prevalence was twice as high as reports seen in Saudi Arabia, Korea, and even in Jamaica via an unpublished study. Now, the high prevalence may be due to its evolutionary adeptness in accumulating multi-drug resistant determinants, thereby increasing the number of catheter-dependent, bedridden, or multiple comorbidity patients that would have severe infections. Low susceptibility towards all antibiotics in K. pneumoniae and E. coli isolates support increased beta-lactamase prevalence rates. Prevalence of 25% for the detection of ESBLs were similar to other reports from the Caribbean and Latin America, and suggestive of the coexistence of these genes as we saw in 2 isolates. And only E. coli and K. pneumoniae were found to harbor the beta-lactamine screened. So the study highlights the concerning elevation in the prevalence of beta-lactamase producing ear pathogens from the nosocomial infections affiliated within the sample populations. The increased resistance against cephalosporins raising an issue, as not many classes of antibiotics currently exist to combat beta-lactamase producers. As such, further work pertaining to the variants and molecular network governing the resistance and virulence exhibited by these pathogens is necessary to aid surveillance, improve antibiotic treatment regimens, and reduce antimicrobial resistance. We had some limitations. Some of the ESBLs may have been masked due to the presence of other beta-lactamases, such as carbapenemases and AMC beta-lactamases. The absence of a bacterial DNA kit may have caused reduced standardization for purity and concentration. Not all genes and variants could have been tested, which means there could have been enzymes present that were overlooked, and not all antibiotics were used for susceptibility tests due to financial constraints. So in conclusion, UTI-related samples came mainly from female patients. However, the majority of male patients had AMR bacteria. E. coli, followed by K. pneumoniae, were the main ear pathogens and the only ones observed with ESBL prevalence. Meropenem and amikacin were the most effective antimicrobials tested, and only CTXM and SHV were observed amongst the ESBLs screened for, with no TEM observed. Here are some of my references. I'd like to acknowledge the following people: Dr. Thomas Rodriguez, Dr. Stevenson Clark, Professor Gossel Williams, the University Hospital of the West Indies Microbiology Department, and the Department of Basic Medical Sciences Biochemistry Department at the University of the West Indies, Mona. And thank you so much for listening.
Thank you very much, Mr. Stone. Excellent presentation, and thanks for those findings. Dr. Chandrasekhar, do you want me to take questions right after the presentation, or should they all present and then take questions afterwards? Please guide me.
Since the first 4 presentations we are considering for award selection, so soon after the completion of every presentation, please allow maximum 5 minutes for question answer and maximum 15 minutes for presentation. Thank you.
Okay, thank you very much. So the floor is now open for a few questions for Mr. Stone. Let me have your questions, please. Perhaps I will start. Mr. Stone, were you able to look at the usage of antibiotics at the hospital where you conducted the study? Or is that something you intend to do in the future, just to look at the usage of antibiotics and how it correlates with the antibiotic resistance?
Okay, we did not go into detail about the specific use. We had the antibiogram, so it allowed us to see what antimicrobials were tested or are tested when being screened for by the specific bacteria. But in terms of its usage to the patients, it was not explored, but it is something that can be looked at in the future.
Okay, thank you. Any question? Oh, Professor Apako, please go ahead with your question. Thank you.
Yes, Mr. Stone, in your findings, you indicated that there was no blood TEM, and there was blood SHV and blood CTSM. Now, my question is, what could have been the cause of that? For the mere fact that blood TEM is the most common. So how come there was no even blood TEM in your, is it that you didn't use the primer for that, or is it that you didn't look for that? So, or do you have any explanation? Because when you said blood TEM was not identified, whereas it is 100% in many cases, the one that you will find before you find the other ones. Any explanation, please?
Okay, so in regards to the primers that were used, they were the general family primers, so they weren't specific to a variant of TEM. So I can tell you that from the the samples that I screened for, there was no TEM detected. I can't say for sure what would have been the reason for no detection in this particular population, but I have seen the reports where TEM is a prevalent ESBL that is normally found.
Thank you for indicating that the primers, so apparently it is because the primer for TEM was not obviously included, so that's just the main reason. But as for not finding TEM in any collection at any time, anywhere, that is not possible.
Thank you, Professor Apako. Dr. Thomas Rodriguez, go ahead and ask your question, please.
Okay, good afternoon. So I just wanted to confirm, Mr. Stone, and thank you for your presentation. You said you did use the primers for TEM and a general primer, however, you had not yet detected them. Can you comment on whether you're going to go on to any further molecular tests like sequencing and whether you think this will help to clarify what's going on in these strains?
Yes, further work or future work, I would want to rescreen maybe doing sequencing. That would be a lot more, what's the word? Not necessarily, I'd say accurate, but more focused onto whether or not we can actually find TEM in these specific isolates. But yes, we did use a general primer for our PCR, but sequencing could be done in order to kind of confirm whether or not there was TEM found within these isolates.
Okay, thank you.
Okay, thank you very much, Mr. Stone. Excellent presentation. I'm now going to move on to Mr. Bull. And so, Mr. Bull, we invite you to give your presentation on molecular characteristics and antibiotic susceptibility of uropathogens in a regional hospital in Trinidad. Before Mr. Bull speaks to us, though, let me give you a little bit about his background. He has a BSc Biology Biochemistry degree and an MSc in Medical Microbiology from the University of the West Indies. He's a motivated professional with 5 years experience in laboratory settings. I think we want to know that he's goal-oriented and a curious learner with a passion for biological and medical sciences. Mr. Bull is currently training and working for an orthopedic implant company. And he has also served at the Trinidad Public Health Laboratory as a laboratory technician in the COVID response unit and the University of the West Indies as a laboratory research assistant. We welcome you, Mr. Bull, and we look forward to hearing your presentation.
Hello, hi, good afternoon, everyone. Thank you for the introduction. Let me see if I can share my screen. Hi, yeah, we all seeing this?
Yes.
Yeah.
Yes, we're seeing it.
Okay, hi, everyone. Good afternoon. My name is Aaron. My topic was the molecular characteristics and antibiotic susceptibility profiles of uropathogens in a regional hospital in Trinidad. So, quick background. Urinary tract infections are the most common infections, and they are becoming very difficult to treat due to antibiotic resistance. One of these reasons is due to the expanded spectrum beta-lactamases and microorganisms that produce these ESBL enzymes bring about new challenges for clinicians to combat these infections in many hospitals. Aims of my study were to identify the causative agents of urinary tract infections in patients in this regional hospital in Trinidad, to determine the antibiotic susceptibility patterns of the identified organisms, and to determine the ESBL producing organisms from these isolates. So my study was carried out at the Port of Spain General Hospital in Trinidad and Tobago. Study population consisted of adult women and men between ages of 18 and 80. Exclusion criteria: no pregnant patients, no one over the age of 80, no current patients who were on antibiotics or have a current UTI or previously treated for UTI. I use conventional microbiological procedures and molecular techniques in determining my ESBL genes. So my bacteria isolates, 51.5% were gram-negative bacteria, 44% were gram-positive, and the remaining were candida infections. A distribution of positive samples. Incidence of UTIs increased in age, and this could be due to functional defects and additional comorbidities, and females were shown to be more susceptible to UTIs, and this we know is due to the anatomical differences between men and women. The most common causative agents in my study was E. coli, and we know that because E. coli is highly motile and is usually found in normal flora in the gastrointestinal tract. The second most common pathogen was Klebsiella pneumoniae, and the third most common was Staph aureus, and this could be due to indwelling catheters, as this increases the risk factor. My antibiotic susceptibility profiles. So my gram-negative organisms were highly susceptible to aminoglycosides, beta-lactams, cefotoxin, ceftriaxone, and piperacillin tazobactam. This is still some good news because we still saw some high susceptibility rates. However, E. coli and Klebsiella were shown to be resistant to fluoroquinolones, to macrolides, and trimethoprim sulfamethoxazole. Gram-positive organisms were Staph aureus, also highly susceptible to most antibiotics. Staph epidermidis was highly susceptible to most antibiotics. Staph saprophyticus, however, was highly resistant to most antibiotics used. The Streptococcus viridans showed varying levels of susceptibility to the antibiotics, with either 100% susceptibility or 66% susceptibility to gentamicin, ciprofloxacin, nitrofurantoin, norfloxacin, tobramycin, and erythromycin. The Enterococcus species and strep pyogenes were both susceptible to all antibiotics except ciprofloxacin. Erythromycin, however, was the least effective antibiotic against gram-positive organisms. My molecular characteristics. ESBL distribution. The CTX gene was the most prevalent and was found in 23.5% of organisms, followed by the TEM gene, and then SHV gene was the least found. Here are my PCR results, showing my results for the CTX gene, my TEM gene, SHV gene. So, in conclusion, the most prevalent organism that caused urinary tract infection in this study in Port of Spain General Hospital was E. coli. The gram-negative bacteria showed high susceptibility to aminoglycosides and beta-lactams. They were also susceptible to carbapenem. E. coli and Klebsiella were shown to be resistant to ampicillin, allopurinol, fluoroquinolones, macrolides, and trimethoprim sulfamethoxazole. The Providencia species and Enterobacter species were resistant to the third generation cephalosporins. And it is to be noted that the ESBL combination with the CTX and SHV gene, they were shown to be resistant to all beta-lactams. So this could be something that further studies can be done. This was a patient who was in and out of the Port of Spain General Hospital for 6 months with a recurrent infection. So we see that antibiotic resistance is a problem, and we have patients who it's directly affecting their lives. So to conclude, the relative high number of ESBLs found in the relatively small sample is of great concern. New protocols and measures need to be put in place to ensure antibiotics are used properly. Antibiotic stewardship programs need to be implemented that these can optimize the use of antibiotics to effectively treat infections and reduce antibiotic resistance. I'd like to thank Professor Akpaka, Dr. Unakal, Dr. Kuradi, Dr. Hassan Khan, and Dr. Shiraz Mohammed, who helped me throughout my project, and Dr. Renan Thompson with all his help in the lab. Couldn't have done it without him. Thank you, everyone, for your time.
Thank you so much, Mr. Bull. Thank you for that excellent presentation. Can you tell me, I'm not seeing a lot about the patient profile. I'm not sure if you didn't include it or if you perhaps weren't intending to look at that this time around. I'm not sure if I missed that.
Patients were between 18 to 80, male and female. My inclusion criteria, patients who came to the hospital with urinary tract infection symptoms. So they have had a fever, lower flank pain, burning sensation when urinated, and then my exclusion criteria were no pregnant women were allowed in the study, no patients over 80, No patients who are currently taking any antibiotics or treatments with UTI.
Okay, so these were patients who were admitted with UTIs, not patients who got UTIs while they're in hospital.
These are
Right?
patients who presented with UTI symptoms.
Right, I just wanted that clarification. Thank you. And we're open for other questions. Any other questions for Mr. Bull?
As I know.
I don't know if I want to let you go that quickly, Mr. Bull. I'm sure you want another question or two, right?
I don't mind one or two.
In the future?
Yeah.
No, just that. In the future, where do you want to go from here? I know you may, yes, just tell us again where you want to go from here.
Oh, well,
I'm sure this has whetted your appetite for more of this.
yes, I'm actually looking to, torn between doing my PhD and continuing my studies with Professor Akpaka, or making a full 180 and going back to school to study medicine. So it's either or at the moment.
Okay, in this life you can do both, okay?
I think so too. I have to talk to Professor Akpaka next week and see what he thinks.
All right, thank you so much for your
Thank you,
presentation,
take care.
Mr. Bull.
Thank you very much.
Bye. All right, so we welcome our third presenter to the podium, and that would be Carlos Rampasad. And Mr. Rampasad is going to be talking to us on urinary tract infections among patients attending a district health facility in Trinidad. And so, as is my custom, let me tell you a little bit more about Mr. Rampasad. He's a graduate of the University of the West Indies, where he pursued a Bachelor of Science in Biology with specializations in biotechnology and microbiology from the Faculty of Science and Technology at the University of the West Indies in Trinidad. Mr. Rampasad honed his passion for microbiology for further completing the MSc in medical microbiology at the Faculty of Medical Sciences, UWI. He actually has a couple journal articles that you would find interesting. He talks about adiponectin and its role in obesity-associated colon and prostate cancers. And in another paper, he takes a look at the Mayaro virus detection. And these were published in the Critical Reviews in Oncology and Hematology and Pathogens and Global Health. So without further ado, we welcome Mr. Rampasad to give us his presentation.
Good afternoon, everyone, and thank you for being present today. I hope everyone can hear me.
Yes, we can.
Great. And thank you for the introduction, Chair, and good afternoon once again. Today, I'll be presenting on my thesis, urinary tract infections among patients attending the Chaguanas District Health Facility in Trinidad. I always like to start off my presentations with some background, so that way we can have an idea of what I'm going to talk about. I'm going to discuss the objectives and how I studied my objectives, as well as review my results and discuss the results, and a short discussion on the conclusions made on the study. So, what are urinary tract infections? Urinary tract infections refer to such where microorganisms invade the urinary tract through the urethra and eventually multiplying in the bladder, causing infection. It can be classified in multiple ways. It can be complicated or uncomplicated, upper or lower, or symptomatic and asymptomatic. It forms as a result of the system's defenses failing. The most common invader are bacteria, with the most common being E. coli. Though the system is exposed to a plethora of fungi and viruses. The urinary tract system is mainly inundated to gram-negative organisms, though gram-positive organisms can also be isolated, with the most common being Staphylococcus. And the pathogenesis and the way that they take on the infection is all based on the organism's virulence factors, their biological behaviors of the host, as well as the host defense mechanism. In the development of my thesis, I noted that information related to UTIs in Trinidad were more focused in the northern and southern regions of the island. The vast central area lacked information on prevalence, antibiotic susceptibility patterns, and associated risk factors. And as a result, my objectives circled around these areas, where I sought to determine the prevalence of UTIs among patients attending the facility, while also determining the antibiotic resistant patterns of the organisms isolated, and also determining the associated risk factors among the patients attending the Chaguanas District Health Facility. Based on the review of literature, I hypothesized that women would have been more common to have UTIs than men. The causative agents would be mostly gram-negative bacteria, and the risk factors would be just about the same as those in other published information. So how did I execute? Well, first off, I had to sort out the consent of the patient to have their sample taken, as well as have their personal information recorded. Presumptive analysis was performed, where I did a dipstick test to see if there were any anomalies within the sample, followed by microscopy. The samples were worked up using the CLSI guidelines, using Kled, blood, and McConkey agar for isolation, and Mueller-Hinton agar for AST patterns. The data that was generated was looked at and analyzed using SPSS version 20. So what was found? In figure 1, you can see that a total of 150 samples were collected, with 49 males being present and 101 females being present in the study, with the most popular age group being 20 to 29. If we look at figure 2, which compares symptomatic versus asymptomatic presentations, you can see that the females farly exceeded those of the males. And if you look at the orange bars, you would see that symptomatic females outweighed those in the study as compared to symptomatic males. In diagram 3, we have the frequency of male and female cases of UTIs giving significant bacteriuria, referring to bacteria isolated from urine. This will be referred to as SB going forward in the presentation. You can see that we had the majority not having any symptomatic bacteriuria. You would see the bars in green. You can see, however, if we look at the red, orange bars present, you can see that we have symptomatic and asymptomatic isolation for both male and female cases. And you could also see that within the females, we had greater amounts of isolates than compared to the males. If we were to sort my data according to age, you can see that the persons, as I said earlier, we will have the most popular age group being between 20 to 29, with a slight distribution to the left as a result. And if we were to sort by sex, we would see that in females, both asymptomatic and symptomatic, were much greater to have SB as compared to males. Though we had a very small population of diabetics in the study, it was seen that type 2 diabetes were more common than that of type 1, and type 2 diabetes also had greater amounts of SB present. Within the study as well, I looked at the history of urinary tract infections, if persons had recurrent urinary tract infections. And what was noted that persons who had a history were more likely to have SB being isolated. So figure 8 refers to the frequency and the types of bacteria that was isolated. A total of 63 isolates of the 150 samples taken were obtained, with a total of 11 organisms isolated being identified using manual methods. A total of 7 gram-positive organisms were identified and 4 gram-negative organisms were identified. You can see from here that using manual methods, the most predominant organism was Staphylococcus saprophyticus. Upon referral, and I thank CAFA for assisting in this project as well, the frequency and types of species were changed. It was more recognized that from the 11 organisms, we now had 17 organisms. And this can be a result of the limited biochemical panel that was probably used in the manual method. Upon the new results, I would say, using automated and panel-based methods, you can now see that Proteus mirabilis was the most common organism after being readjusted. And the goal of my project, the real goal, the antibiotic susceptibility patterns generated were unique as compared to those that were already published. It was important to note that erythromycin, penicillin, ampicillin, and nitrofurantoin were common between multi-drug resistant patterns for both the gram-negative and gram-positive isolates. And if you look at figure 11, you can see that Proteus mirabilis, you would see that it was resistant to 12 of the isolates out of the 13 was resistant to nitrofurantoin, erythromycin, and penicillin, as well as the one additional being resistant to 2 of the 3. With all this data generated, what did I really conclude and what did I really find out? What new information was really put out there? And you will see that the type of diabetes, a history of a previous UTI, and antibiotic use for the infection had significance in the development of UTI among both the symptomatic and asymptomatic patients. The most prevalent organism isolated in the study was Proteus mirabilis, with having 13 isolates or 20.6% prevalence, followed by Enterococcus faecalis and Enterobacter cloacae. The study also determined the multi-drug resistance to 2 or more drugs. And within the organisms, you would see that there was a 60.3% level of multi-drug resistance to 2 or more drugs within the study. And at this point, what would be the way forward for the central region in Trinidad? And I can definitely say it can be noted that there needs to be increased regulation of antibiotics passed over the counter. The dispensing of antibiotics OTC routinely done for uncomplicated presentations should be halted. The prescription of nitrofurantoin, erythromycin, penicillin, and ampicillin in the central region should be reduced and used only as a last resort to treat UTIs due to the number of resistant isolates obtained in this study. Additionally, as a tropical region, there should have more access to public information resources in terms of the prevention of UTIs and the available treatment options for persons presenting with such, especially seeing that the cases of recurring UTIs and the person with diabetes were the 2 major risk factors seen to be significant in this study in particular. It was also recommended that to have patients have regular checkups due to the high number of asymptomatic participants having isolates from this study. I would like to really thank my supervisors, Dr. Unakal, Professor Apaka, Dr. Kurade, and the members of staff at CAFA who did help me along the way in order to achieve the plethora of information that was generated from this study. And I thank everyone for listening this afternoon to my presentation. And as in life, as I always love to say, answers are not always guaranteed, and questions are. But thank you very much, and I'm open to questions.
Thank you very much, Mr. Ramprasad. That last statement definitely opens you to questions. So I join you in inviting questions from the audience. Thank you for your very good presentation, sir. I wondered about, well, let me wait a minute and hear from the audience. Please, we're open for questions. Okay, so Dr. Reynolds Campbell wants to know how you would suggest. I'm sorry, Dr. Reynolds Campbell, that question just went before I could read it. So let me see, it's gone. I'm seeing it. Okay, can you put that in again in the chat, Dr. Reynolds? In the question and answer. All right, can you suggest how you would implement regulations in a population that is so used to being able to access drugs? And if you answer that, yes, okay. I'm sorry, go ahead.
You can see my facial expression from that question. I think given the history of the region, I think we need to move more from an individual health approach to more of a one health approach when it comes to our antibiotics and the way that it is really being distributed. There needs to be more of an integration of the pharmaceutical industry with interactions with doctors and the hospitals. That way, when somebody is going to actually be treated We look at the person on a whole and adjust the patterns as needed. And when persons are going to present, we are now changing the way that we're going to teach across the board. So it's not going to be, okay, somebody's presenting in the community and they're going to say, I have a urinary tract infection. I don't want to pay the extra to go to a doctor. So I'm just going to ask the pharmacist, hey, this is happening to me. Can you give me something? We need to, that One Health approach is going to now provide additional information, as I would say lower down in terms of the recommendation. With having the access to that information as well publicly, we would also know that persons can't just go to a pharmacy and get these drugs by itself. It has to be sought out in a particular way. So maybe our approach needs to be changed, which can take time, but it is possible for us to do.
Okay, thank you. Dr. Reynolds Campbell also wants to know how easy it was for you to get participants.
It was not very easy because participants, when they see a student presenting at the health center, they would have, I would have had to interact with them at that time saying, this is what I'm doing. I would really appreciate the help. And some days it would have been very, very slow. I would go to the health center and not collect a sample, not even one. And then other days I would have where I collect 10 in a row and I would be so happy because I would have actually had work to do from sample collection. So it did take some time and the willingness for sample collection was a little bit difficult, but I'm glad that it was achieved.
Okay, thank you. I see Dr. Tom's Rodriguez's hand has been up for a while, so I'm going to ask her to pose her question, and then right after that, I'll ask Khalil to ask his question as well. So Dr. Tom's Rodriguez, go ahead.
Okay, thank you. Thank you, Carlos, for an excellent presentation. I just wondered whether you could comment further on the use of nitrofurantoin and whether you saw where there was inappropriate use in upper tract infections.
Upper urinary tract infections. So I did have some literature where there was inappropriate usage. However, it was not a local study. I want to think this was from within Latin America, but the issue with it was that with the use of nitrofurantoin, it is not something that is usually prescribed or recommended for usage, being that the effects of it can be, the bads can outweigh the goods with the use of it in certain patients, especially being you have patients that will present with non-communicable diseases that are linked to urinary tract infections. So if I would really hope that answers your question, but I can't elaborate further. Maybe later on we can have a communication.
Okay, thank you. I'm really hoping there is no use in upper tract infections. But thank you so much. All right.
Thank you. Khalil Ashraf.
Yes, good day. Good job, Carlos.
Khalil, thank you very much.
Question I have. When you did your biochemical testing, your phenotypic at the lab, you got saprophyticus as the major player. However, when you did the automation, a gram-negative Proteus, if I remember correctly. I want an explanation, if you can offer any explanation to that, firstly. And secondly, what automation did you use? What machine did you use?
I think I will answer.
Sorry, 1 second. Before you answer, Carlos, Khalil, do you have two instruments on by any chance? There's an echo. Am I the only one hearing the echo?
Yes. Okay, yes, I do. Because we're monitoring the conference from here, a group of us. Sorry about that.
Okay.
Okay. So to answer the second question first, the automated methods used were the Vitek 2 Compact, and the panel-based methods were the API strips. Sorry about that. Took me a little bit to remember. Both for gram-positive and gram-negative, where the organism may not have been present. In terms of the saprophyticus being the most prevalent, that would have been because of the amount of biochemicals that I would have used due to the limitations of the amount of biochemicals, which was 7 biochemicals used, the identification would have been limited. Additionally, which I won't go back, but you can also see that Staph saprophyticus with the automated methods was also identified. Now, saprophyticus can be noted as a contaminant as a result of poor sample quality. So this can be that upon instruction from the nurses and the doctors on how sample is supposed to be collected for a clean midstream urine sample, it could have been that they could have completely disregarded the instructions and not used alcohol wipes to clean the area that was provided and just feed into the cup. And that is a reality as well in terms of sample collection, because the quality of your sample, if you have bad sample in, you have bad results out. So that could have been two of the reasonings to why saprophyticus came up higher using the manual methods as compared to using the automated and panel-based methods that had close to 20 to 40 different biochemicals used for identifications, which cross-reference to the CLSI guidelines.
Thank you very much.
Just before you go, Mr. Rampasad, 2 points. One, you mentioned you included in your study erythromycin. Is that a common feature? Is erythromycin used for UTIs, or that was just for completion of gram-positives?
It was used within the study. However, there is a list of antibiotics that are not recommended for the use in treatments of UTI because of the high amount of antibiotic resistance to it. And one of it is one is erythromycin, with reference to your question being asked. But it was included as a result of the literature being reviewed. Because it is a common antibiotic, and it is still included in different panels, it was still utilized within the study.
Okay, thank you. An anonymous attendee wants to know, what about an antibiotic policy for usage in clinics for the treatment of UTIs?
Okay, so that's an excellent point. So in terms of antibiotic policy, from my knowledge, what I understand is that every 5 years or so, each region, and I think this goes throughout the entire island chain and the region, there's supposed to be monitoring of antibiotic susceptibility patterns for bacteria given from whatever isolate that it's coming from, urine, stool, blood, etc. And each particular region in Trinidad have their own policies set, which is all well and good, but a more unified policy needs to be set up as well. As I would have said, the patterns that was observed in South Trinidad and North Trinidad were similar, but we lacked information in the central region. And now seeing the information here, this information can probably now be brought together to have more of a whole idea of what is going on, to probably develop a policy more so for a more island-wide basis. So I do think that can work.
Okay, and just the last comment or question here from Harry Nepal. We need to follow special strategy for urine collection from catheterized patients. He's asking, do you have special suggestion to nurses or other staff members who need to collect the sample?
Specifically to catheterized collection. Now, it is important, and then this is what I would say, that samples are collected as aseptically as possible. If we do not collect samples as aseptic as possible, we increase our chances of having organisms that may not be even affecting the patient at all. In terms of the collection through a catheter, of course, I won't go into the entire process of the collection, but at each step, I think a good recommendation is to make sure that you clean, you sanitize, ensure that you're using clean unopened needles, ensure that you are doing best practice going forward. Just because you want to move fast does not mean it's going to be effective.
Thank you so much, Mr. Rampasad. Excellent presentation and interaction.
Enjoy the evening, everyone. Thank you.
Thank you. And now we move to Kevin Hohenkirk. I would love some help in the pronunciation of that surname. I think I'm allowed that. So Kevin, can you just, when you start, tell us how to pronounce your name? Welcome.
Good afternoon, Dr. Nicholson.
Hi, good
It's
afternoon.
Kevin. It's actually Kevin Hohenkirk. It's Dutch.
Okay, great. Thank you. I'm sure others benefited from that as well. I don't think I was the only one. All right, welcome and thank you. We look forward to hearing your presentation. Let me just say a little bit about you before you do present. So Kevin is currently a fourth-year MBBS student at the University of Guyana. Special congratulations, Mr. Hohenkirk. He holds a BSc in Medical Technology from the University of Guyana and an MSc in Medical Microbiology from the University of the West Indies in St. Augustine campus. Mr. Hohenkirk has a wide range of research interests, specifically in infectious diseases, with particular focus on antimicrobial resistance and immunotherapy. He co-authored a research paper entitled Chemotherapy-Induced Neutropenia and Other Outcomes Among Breast Cancer Patients in Guyana. And this was actually published in the West Indian Medical Journal in 2017. He is also an alternate country representative for Global Fund, HIV, AIDS, Malaria, and TB project. He has worked as a lecturer of immunology, parasitology, and microbiology at the Lincoln American University, where he also functioned as a coordinator for preclinical sciences. We look forward to this presentation.
Thank you, Doctor. I'm actually getting some technical difficulties.
Kevin, let me help you sharing your slides for you. Hello, Kevin, you with us? Let me share your slides for you.
Thank you, Doctor.
Just a moment. Yeah, you are good to go now.
Okay, good afternoon, everyone. Thank you to the association for giving me the opportunity to present my topic, titled Urinary Tract Infection Among Pregnant and Non-Pregnant Women at the Linden Hospital Complex. My research team consists of Professor Akpaka, Dr. Wilpal, Dr. Adonia Benjamin, and Dr. Next slide. So this is the brief objectives that we'll be looking at today. Moving on to the aims of the research. The aim is to determine the prevalence, antibiotic susceptibility pattern, and associated risk factor of urinary tract infection among pregnant and non-pregnant women at Linden Hospital Complex. On to the objectives. So we had four major objectives: to determine the prevalence in both target group, predisposing factor, etiological agent of urinary tract infection among both pregnant and non-pregnant women, and finally, the resistant pattern within the study group. Moving on to the literature review. So Ralph et al. In 2015 defined urinary tract infection as a pathological process characterized by microbial entry and alternate colonization of the epithelium of the urinary tract. According to a publication by Mesendi et al. Titled Prevalence of Urinary Tract Infection Among Pregnant Women in Mwanza, Tanzania, women are at an elevated risk for urinary tract infection due to anatomical and physiological factors. And when these factors are coupled with pregnancy, which is accompanied by even further changes, the risk of infection drastically increases. I remember back in 2016, while I was reading the literature for a topic for my thesis, I came across this article by et al., published in 2009. It titled The Treatment of Urinary Tract Infection in Pregnancy. It highlighted a possible poor maternal and perinatal outcome UTI pose during pregnancy if left untreated. And these include preeclampsia, eclampsia, intrauterine growth restriction, acute respiratory distress, sepsis, preterm delivery. There's just to name a few. Furthermore, the American College of Obstetrics and Gynecologists revealed that UTI is one of the most common cause of admission in the obstetric ward. It is for this reason we believe that the World Health Organization recommends compulsory screening and testing for urinary tract infection in pregnancy for as early as 16 weeks gestation.
Hello.
Hi, Dr.
Kevin, you able to hear me? Sorry for interruption, everyone. Apologies for that. You able to see my screen, or you are reading your slides?
I'm reading my slides.
No, please you exit from your slide share, because all the participants are unable to see the slides.
Okay.
You exit from your sharing. Let me reshare it once again.
Okay, great.
Yeah, just a minute. In which slide you were?
I was at slide number 6.
No, is this the one?
Can we start over?
Yeah.
Josh gynecologist, get the technician to check the computer.
Kevin, which slide you were? Let me know.
I was at slide 6.
No, materials, methods, or objective, like that.
Literature review.
Literature review. Okay, just a moment. Right. Continue, please.
All right. So for literature review, Ralph et al. In 2015, they defined urinary tract infection as a pathological process characterized by microbial entry and ultimate colonization of the epithelium of the urinary tract. According to a publication by Massendi et al., titled "The Prevalence of Urinary Tract Infection Among Pregnant Women in Tanzania," basically stated that women was at an elevated risk for urinary tract infection due to anatomical and physiological factors. And when these factors are coupled with pregnancy, which is accompanied by even further risk, the risk of infection drastically increased. So I remember in 2016, when I was going through the literature for just trying to find a topic for my thesis, and I came across this publication titled "The Treatment of Urinary Tract Infection in Pregnancy," and it highlighted poor maternal and perinatal outcomes UTI pose during pregnancy. And this includes preeclampsia, eclampsia, intrauterine growth restriction, sepsis, and the list goes on. So further research found that the American Association for Obstetrics and Gynecologists revealed that UTI globally is one of the most common causes of admission in the obstetrics ward. So for this reason, the World Health Organization, they recommend compulsory screening and treatment for urinary tract infection in pregnancy as early as the 16th week of gestation. And the thing is, this is standard care in the developed world, and it should also be standard care in third world countries like Ghana. But this is done mostly in urban areas like Georgetown, New Amsterdam, Saudi, Malia, and even Linden Town Center. But anecdotal evidence from colleagues working in rural hinterland areas suggests that this is not common practice. And this is where—
Excuse me, I'm so sorry to interrupt you again. Kevin.
Sure.
You have been using slides, right, Kevin?
Yeah, I was using, no, yeah, I'm using slides. I was using slides.
So,
But I'm
Kevin,
using Dr. Protocol slide sharing.
Kevin, you are able to see my slide sharing, right?
Yeah, no, but I'm not seeing it now. It just cut off.
You are in discussion now. Right. No, you are not sharing your screen. Now you are out of your screen, right?
Yeah, no motion. Don't understand what's
Okay.
Dr. Unicall, can you stop sharing? Let me try to share and see what's gonna happen.
Yes, please do that.
All right, great. Because I get a technician here, so we can probably help.
All right, please.
Please send the technician. All right. So this is.
Yes, this is good.
Go to slideshow. Click on
Yes.
slideshow.
Okay, great.
Okay.
Yeah, click on slideshow. Lower corner, you will see a kind of umbrella kind of symbol. Right at the bottom. Okay, yeah, click that one. No, Kevin, come down.
Controlling anything, sorry.
No. Yeah. You
Right, ma'am.
bring down your cursor. Share it again. Oh, okay.
I was the one trying to share for him, but I'm allowing him to. I'm just waiting to see if he can get through. So the slide we're seeing were from me.
We were able to see that your slide, Prof.
All right, so I could share that.
Yes, please.
All
Yes,
right.
please.
No, Kevin has started. So
Yeah, he has started, Prof. Let us wait.
yeah, let's just see what it will.
Kevin, if still you have problem, we will request Prof. Akpaka to share it.
Okay, let me try one more time.
Okay, hold on. You locate your PowerPoint from the screen. Kevin, open your PowerPoint first before sharing. Then click on share screen. Did you open PowerPoint?
Yeah, I did.
Okay, hold on. Okay. So which mode it is? All right, click on the original one, left side, or the double click on first slide. The left corner, there will be close option. It is CACM fine. Okay, good. Go ahead to your appropriate slide and continue. Thank you.
Okay, great. Do you guys want me to start back or?
No, from where you start before.
From where I start. Okay. Okay, guys, sorry about that. So upon further research, we found that the American Association for Obstetrics and Gynecologists, they revealed that urinary tract infection remain one of the most common cause of urinary tract infection, the most common cause of admission in the obstetric ward. And for this reason, we believe that is why the WHO recommend compulsory screening and treatment for UTI in pregnancy. And this is common practice in the developed world. And it should be common practice in countries like Guyana, developing countries like Guyana. But while this is done in most urban areas like Georgetown, New Amsterdam, Surrey, Badia, Linden, anecdotal evidence from colleagues working in rural and interland area suggests that this is not common. Because of that, we decided to embark on this research. The thing is, Linden was chosen for this research because it's the capital and the urban center of Region 6. But the farther you go from Linden, the communities in Region 10 become more sparsely populated and more difficult to access, compromising the standard of care. So therefore, Region 10 was the perfect combination of rural, urban, and interland setting. I'd also like to register the fact that this research is the first of its kind in Guyana, and I hope it set precedent for guidelines for screening of urinary tract infection among pregnant women, and also for the implementation of strict guidelines regarding the use and distribution of antimicrobials. So let's move on to the materials and methods. So this is a laboratory-based cross-sectional study. A total of 250 samples were collected from the Linden Hospital complex, of which 132 were pregnant women taken from the antenatal clinic, and 118 were non-pregnant women from the outpatient department. Samples were then transported to the Eureka Medical Laboratory for urinalysis, culture, and biochemical identification. The positive samples were then sent to University of the West Indies microbiology lab in Mount Hope for antibiotic susceptibility. All right, so let's get into the juicy stuff, the results and discussion. So the prevalence of UTI among pregnant women was 29.3%, and non-pregnant women it was 31.6%, which is significantly higher when compared to studies from other parts of the world. For example, in Australia, a study done by Bukulele et al. Revealed the prevalence of just 4.9% among pregnant women. Another study by Hernandez et al. In Mexico revealed a prevalence of just 8.9%, and in Ethiopia just 9.8%. And this compared to Guyana's 29.3% among pregnant women. But an important point to note is that the GDP of these countries at the time of the study was significantly higher than Guyana. And this could be a possible explanation for the relatively low incidence of or low prevalence of urinary tract infection, because a higher GDP would mean a more disposable income for spending on health care. So more closer to home, a study from northern India enrolling pregnant women using the same recruitment method that we use in our study. It reported urinary tract infection. The prevalence of urinary tract infection was a lot closer, of about 25.5%, which is a lot closer to Guyana's 29.8%. I know by now you guys probably are wondering, why is it that non-pregnant women, the prevalence of UTI among non-pregnant women are higher than that of pregnant women? And while it is widely accepted that the anatomical and physiological changes that occur during pregnancy place women at a higher risk for UTI, in our study, it was noted that non-pregnant women recorded a higher prevalence of about 2.6% compared to pregnant women, which is very strange and surprising. But we think that this could have been attributed to the fact that in our study, non-pregnant women were recruited from the outpatient department and may have had undisclosed underlying condition that predisposed them to urinary tract infection. So let's move on to the etiological agent, results of the etiological agent. Well, globally, it's widely understood, it's widely accepted that E. coli is the most common cause of UTI among any study group. And this was the same in our study. E. coli was the main cause of UTI in both cohorts accounting for 43.6% in pregnant women and 35.1% in non-pregnant women. Then it was followed by Klebsiella, which accounts for 28.2% in pregnant women and 24.3% in non-pregnant women. And E. coli and Klebsiella, they have a very evolved virulent factor that make them the perfect pathogen for causing urinary tract infection. So that may be the reason why these two organisms are the most prevalent cause of UTI worldwide. And this finding is consistent with that, with other studies globally. All right, so let's get into some interesting stuff. The antibiotic susceptibility pattern profile. So in the total study population, E. coli account for 97.7% resistance, and Klebsiella account for 44.9% resistant among cephorami. Let me repeat that again. E. coli recorded a resistant pattern of 97.7% resistant, and Klebsiella close to 45% resistant against a second generation cephalosporin. And when we look at ceftazidime, a third generation cephalosporin, E. coli registered 42.8% and Klebsiella 50.2% resistance. Ladies and gentlemen, we're talking about the second and a third generation cephalosporin. And in Guyana, these are the resistant pattern. And it gets worse. It gets worse. Klebsiella accounted for 45% resistance against ampicillin, and E. coli represented 48% resistance towards ampicillin. These are very alarming stats because beta-lactam class antibiotics such as amoxicillin, ampicillin, and cephalosporin are usually go-to drugs for treatment, not only UTI, but most infections in pregnant women because they're generally safe to use in pregnancy. Additionally, these figures are significantly higher than those reported in 2014 by the World Health Organization Global Surveillance for Antibiotics, and it paints an alarming picture for the future of Guyana as relates to treatment of UTI and infectious disease in the whole. We believe that these disastrous susceptibility patterns can be attributed to a lack of enforcement of laws governing the sale of antibiotics. On the sale, the use and distribution of antibiotics in Guyana, and we really need antimicrobial stewardship as well as it highlighted the necessity for investment in research for a new and effective antibiotic that are safe to use in pregnancy. All right, so moving on to the socioeconomic status and its risk for urinary tract infection. So as relates to socioeconomic status, unemployment seemed to play an important role in the prevalence of UTI among women in both cohorts of our study. And as you can see in the graph, 81.2% of non-pregnant women had urinary tract infection and 69.2% of unemployed women were diagnosed with urinary tract infection within our study. And this correlates to a Bangladeshi study in 2018 by Philippe, which had similar results. Moving on to pregnancy and health. So these figures showed the trimester pregnant women were diagnosed with UTI. And as you can see in the pie chart, it seems to be an upward trend. And the more advanced the pregnancy, the higher the prevalence, with the third trimester registering a prevalence of 46.2%. Here, there were a total of 20 women with underlying conditions, 55% were diabetic, and 40% had recurrent urinary tract infection. So these statistics are not surprising because diabetes mellitus have long been associated with an increased risk of urinary tract infection. Moving on to hygiene and practice in our study, women who wipe back to front and wipe both way after bowel movement accounted for 46.2% of UTI cases. And this may be due to the introduction of bacteria from the stool and also the close proximity of the anus to the vagina. All right, so to decrease the prevalence of UTI among women and tackle the high rate of resistance in Guyana, I'd recommend screening for UTI. Should become standard practice in antenatal clinic. All pregnant women throughout Guyana, 16-week gestation. Ministry of Public Health should design and implement stricter policies regarding the sale and use of antibiotics in all settings. This includes veterinary, agriculture, and medicine. Antimicrobial drug resistance is on the increase, and as such, it's imperative to monitor these events through regular research and surveillance. And this may provide data regarding a local antibiotic susceptibility pattern, which will help physicians to prescribe more effective empirical treatment. Finally, ministry should embark on a nationwide health promotion campaign in the form of advertisement on TVs, radio, and even social media aimed to educate women on vaginal health and UTI prevention. Since the prevalence of UTI in both study population, in women generally, are way higher compared to other studies in the world. So based on the data from our study, antimicrobial resistance is a serious public health concern, and we all need to act urgently. Prevalence of UTI among pregnant women and non-pregnant women are significantly higher compared to that. Surprisingly, the prevalence of UTI among non-pregnant women in our study were higher than that of pregnant women. And in both studies, socioeconomic status is a major risk factor for UTI in pregnant women, and the third trimester and diabetes mellitus were significant risk factors for UTI during pregnancy. So that has brought me to the end of this presentation. I'd like to take this opportunity to thank my supervisors, Professor Akpaka, Dr. Unakal, Dr. Adonia Benjamin, and Dr. Quincy Joan. Also my friends, plays an important role in getting up the samples in sample collection, the sample collection process. Also the Eureka Medical Laboratory for allowing me to do my testing there free of charge. And for you guys for listening to me, I'm sorry for the technical difficulties. Are there any questions?
Yes, thank you so much for that, Mr. Hohenkirk. Thank you for that presentation. And yes, we do have questions. So I will take those that are written first, and the other persons can just line up for their questions after. Dr. Lewis is asking, what do you think is the reason that infection is higher in unemployed women?
So the thing is, when there's so we find based on studies, countries that have a lower socioeconomic status, there are higher rates of infection, and similarly, women that are not employed, the money that they would use for other stuff, the money that they would get, there's not enough money to use for health that they would use towards their health. So that may be one of the reasons why women, there is a higher prevalence of UTI among unemployed women.
Okay, well, actually, the second question by Harry Nepal it's the same question. So we now open the floor for other questions to come in for Mr. Hohenkirk. While we're waiting, I wondered about how you selected the unemployed women. And you commented on it, but I don't know if I'm still clear. I'm any clearer as to how you did it. Did you have a questionnaire? Did you have any criteria to rule out particular persons, or you just took any female who was not pregnant? And this was from a hospital setting. The place you mentioned was a hospital, right?
Yeah, it was a hospital. So what we did, there were inclusion and exclusion criteria. So some exclusion criteria included if it said that the woman was on antibiotic, they were excluded already. If they had known pathology, they were also excluded from the study. Other than that, we basically randomly selected women and they answered a questionnaire. That is how we were able to identify if they were empowered or not.
Okay, all right, thank you. Any other questions from the floor?
Jerome Walker's hand is up. Is it for a question? Is it a comment? Jerome Walker.
I'm sorry, what was that, Patrick? What was that, Professor Apako?
Someone's hand was up, but it is down now. The person has taken it down.
Okay. All right, hold on, let me just see, I think there was another point. Yes, an anonymous attendee wants to know if nitrofurantoin is used in Guyana for UTI. Do you know?
Yes, it's actually one of the go-to drugs for urinary tract infection, but it's not used in pregnancy.
Okay. All right, well, thank you so much for a great presentation.
Thank you, Dr. Nicholson.
Sure.
Thank you, everyone.
So we want to move on now to the final presentation for this afternoon. And that would be by Dr. Nagasar, Dr. Rajiv Nagasar, who is going to tell us about building a surveillance system for antibiotic resistance in Trinidad and Tobago, resulting in reporting to different entities. So having trained as a medical doctor, Dr. Nagasar pursued postgraduate studies in medical microbiology at the University of the West Indies, Mona, and he is now a medical microbiologist, has been for a while. He also has a postgraduate diploma in emergency medicine and has received management training in Trinidad and Tobago at the Arthur Lockjack Global School of Business. Dr. Nagasar is currently pursuing a master's in health administration. And he has actually been serving extensively in the area of microbiology in Trinidad and Tobago. He is working on building national capacity in the areas of antimicrobial resistance, surveillance, and testing. And his presentation, I think, will aptly demonstrate this. Dr. Nagasar, we look forward to hearing about the work that you're doing in building a surveillance system for antibiotic resistance in Trinidad and Tobago. So welcome.
Thank you. Can you hear me?
Yes, I can, and we're seeing your
Can you see
slide.
the screen? Okay, thank you. So good afternoon, everybody. I'm doing a presentation on a surveillance system that we're building in Trinidad and Tobago. As you can see on the left side of the screen, there's public health surveillance and public health research. And we know that public health research in the public sector and surveillance in the public sector is used more for decision making and action, although we want it for knowledge. Whereas more in the research setting, you would more use it for knowledge, right? Moving to the next slide. So sometimes my slides tend to stick a bit, right? So I'm just going to. So this is an overview of my presentation. So basically, a surveillance system is part of the national action plans for antimicrobial resistance in many countries, right? And countries can submit data to WHO GLASS platform, but they must work on building their surveillance and testing system. You must be able to test because you must have some kind of data you can gather. Attainment of samples, human resources, procurement, and maintenance issues for antimicrobial resistance testing at laboratories involved in surveillance system are important elements of a surveillance system as noted by authors. Laboratory capacity building, training, and diagnostic stewardship are critically examined. So what really were the objectives of this? This was basically a desktop review. We were looking to explore the components of the surveillance system in Trinidad and Tobago, to explore possible gaps and to explore any successes and lessons learned. So ethical approval was granted for this study. It was mainly a qualitative study. So basically, this was a desktop review on sources of data that which included primary or secondary sources. There was no identifying information that was sought. We would have used document reviews, observations, and interviews as possible sources of data. Data for a surveillance and testing system was explored from appropriate authorities, and components explored with things like plans, monitoring evaluation, components, budgets, and so on. Right? A semi-structured open-ended data collection instrument was used. So we did use an instrument and a logical model, and a diagram was used to display the qualitative findings. Right? So in the results now, interviews were unsuccessful. So basically we had to resort to, well, I had to resort to secondary data. This was mainly observations and document reviews, and the samples that the sample information that was sent to the surveillance system was mainly from blood and urine. So this diagram basically shows the building of the surveillance system from 2020 to 21. In 2020, we started with one site, and then in 2021, we went to two sites, so RHA1 and RHA2. As you can see on the top, going to GLASS 2020 and GLASS and PLISA 2021. So in 2020, we became a part of GLASS and we shared data with GLASS. And in 2021, we shared data with GLASS and the PLISA platform, which is a PAHO platform, right? And this information goes internationally. So this is a logic model, right? Showing inputs, activities, outputs, and outcomes. At this stage, we wouldn't really expect there to be outcomes. Those are the expected outcomes in the medium to long term. But in reviewing the data, the inputs included human resources, which fed into activities such as allocation of a focal point for staffing, training through country cooperation, which resulted in output such as a number of persons with increased technical capacities to support the national surveillance system. However, there was really just one focal. A number of persons trained in AMR testing, a number of persons trained in HUNET. During this study, we tried to send information for one interview with one technician that was doing the external quality assurance component, but we weren't able to do that because the technician was unable to respond at the time. So apart from human resources, time was another input. So the focal point had to have time because that was not the focal point's only duty. And during their time engaged in training, cooperation, and coordination. Funding for this activity mainly came from external sources, so did supplies. And the funding supported capacity building and external quality assurance, which in AMR, which later was built to fungal testing. So we have yeast, right? So to build a surveillance system, we really depended on external funding. Raw materials, again, were external, and there was at least one laboratory performing external quality assurance, right? So this is what the PLISA platform looks like. This is Trinidad and Tobago data that was shared on the PLISA platform, and this is the GLASS platform, what it's like. Right, so the discussion and conclusion, basically support from a focal person was needed for data entry, regular schedule, communication, establishment, and procurement of supplies, some supplies which we expect to receive soon. And these supplies would be given by an international body. And these were some of the identified solutions to close the gaps in resources and technical, and even resources such as testing supplies and so on. Right? Small countries could learn from this experience to start testing. You don't have to have everything fully functional. You need to obviously get a certain level of functionality. But not because you're a third world country, it means you can't join WHOGLASS and start sharing data, right? This data, and this information could be used for national policy planning and budgeting, and for international cooperation, and especially for filling budget and technical gaps. So really, that's all for me. Any questions now I'll take at this time.
Thank you very much for that, Dr. Nagasar. And so we welcome questions. Dr. Nagasar, we realize that you wouldn't have been able to give us the full extent of your exposure during this time, but for those of us who may not yet be onto GLASS, what are some of the challenges that you experience, especially in the early stages?
So building the surveillance system, collecting the data was a challenge, refining the data collection tools. We started sharing in 2021 with one lab, because basically that was the lab I was working at. And we tried to collect from other laboratories, but we needed to refine a tool. And that tool was better refined during 2020. We got data from another laboratory to help us share more data in 2021. So, it's refining and building that system, but also the technical assistance and the funding gaps. So those were some of the gaps. Thank you, over.
Thank you. Thank you, Dr. Nagasar. I think Mr. Rampasad, you're trying to ask a question.
Yes, sorry about that. I can't post any question. I just wanted to find out if there's any PAHO involvement at the regional level when it comes to GLASS.
Well, there's international involvement. I would not be specific about the bodies because, as I indicated, the article approval did not allow me to share names and data and stuff, but there's international cooperation involved. So thank you, and over to you.
Thank you.
The information, I'm sorry. Any other questions at this time? Dr. Nagasar, can I invite you to share your reflections on the early results? Have they helped you in terms of your own, antimicrobial program? Have you been surprised by some of the data that you would have had a different look at them with collecting them and then being able to see them from a different perspective?
Well, Dr. Nicholson, the interesting thing is no. Some of what we expected to see we found. So we found high levels of fluoroquinolone resistance, which is one of the things that stood out in one of the presentations. We found high levels of third generation cephalosporin resistance, which is been shared in 2021, right? So that's to be published in 2022. Right, that will be our first publication on UGLAS with actual data, right? But in terms of using it for actual country information changes, but that's why when I showed you my logical model in the output section, I indicated that we didn't reach that part of outcome, whether it be short, medium, or long term. We really just at the output stage where we're putting out data and we're now trying to make it for decision making, whether we need to set up a center, the ministry, whether we need to set up a center, the Ministry of Health and things like that, for specifically for these things, sort of things. So I hope that answers your question, Dr. Nicholas.
Yes, it certainly does. Thank you so much. Any other questions for Dr. Nagasar? All right, I'm not seeing any in the question and answer section. Not seeing any in the chat. All right, I think that's it. Dr. Nagasar, thank you so much for a very good presentation, very informative. And we might actually contact you if we need some information in this area. Okay?
No, not a problem, Dr. Nichols.
Thank you. Dr. Unikal, I turn back. Sorry. Yes, I'm going to turn back over to you now, sir.
Thank you very much, Dr. Nicholson, for a wonderful job. And Now we are at the last stage of our conference, the panel discussion. I would like to request Dr. Camille and Thomas to chair the panel discussion. To introduce Dr. Camille Thomason, she is a lecturer in Department of Microbiology at the University of the West Indies and consultant clinical microbiologist to the University Hospital of the West Indies, Jamaica. She holds Bachelor's of Medicine and Surgery and Doctor of Medicine in Microbiology from University of the West Indies and has spent an attachment in the Department of Laboratory Medicine and Pathobiology at Mount Sinai Hospital in Toronto, Canada. Dr. Thomas is primarily involved in clinical bacteriology, where she participates in the daily operations of diagnostic laboratory and provides consultation on patients management. Her main area of research are on antibiotic resistance and has conducted several studies in this area. Dr. Thomas is a member of UHWI Infection Control Committee and is involved in daily activities aimed at reducing the spread of healthcare associated infections, thereby reduce the morbidity and mortalities. She is a Christian and member of Bethel Baptist Church Holistic Health Committee and believes that healthcare should cater the whole person. She is member of Caribbean Association of Microbiologists, where she currently serves as secretary, and also she is the ASM Young Ambassador to Jamaica. Having introduced Dr. Camille and Thomas, I request you to take over the panel. Thank you very much for being with us. Good to see you after a long time. Before I hand over to you, Dr. Thomas, I would like to invite as a panelist for this session, Professor Adesh Ram Subhag, who was one of our keynote speakers, and Professor Jairaj. He is also professor in biotechnology and microbiology, Department of Life Sciences at the University of the West Indies. And I would like to invite one of our chairmen in the morning session, Dr. Glendy Reynolds, as well as Dr. Alison Nicholson, to be panelist for this panel discussion. Thank you very much. Now, Dr. Thomas, the floor is yours. Thank you very much.
Thank you. Thank you so much, Dr. Unical. And it is my pleasure. Good afternoon, everyone, to chair this session. And we have a distinguished set of panelists, you heard them, who are able to now further answer some questions that you may have on the topic of antimicrobial resistance or anything that they may have presented on. I too have some questions for them. You would have been introduced to most with the exception of one. And so in addition to Dr. Boris Castillo, Dr. Reynolds Campbell, Dr. Alison Nicholson, and Professor Ram Subhag, I would like to also introduce Prof. Jaya Raman. He's our other panelist who has not yet been introduced to you, and so I'll now give his a formal introduction for him. Professor Jaya has a PhD in plant pathology, as well as an MSc and BSc in agriculture from Annamalai University in India. He did a fellowship at Kansas State University in the USA, and his research interests include plant microbe interactions, genetic engineering of plants for disease resistance and stress tolerance, metabolic engineering and biofarming of therapeutic proteins and industrially valuable compounds, phytonutraceuticals, marine seaweed products for agriculture and human health, as well as antibiotic resistance in bacterial pathogens. He is a decorated senior lecturer in the Department of Life Sciences at the University of the West Indies, the St. Augustine campus, and that's of course in Trinidad and Tobago. And he has many honors and awards, including being an advisor to the United Nations University Biotechnology Program for Latin America and the Caribbean, And he also had been awarded the UE Vice Chancellor's Excellence Award for Outstanding Research Accomplishments in 2016. Professor Jaya, welcome, and we're happy to have you among our distinguished panelists. So as I said, we have an excellent set of experts with whom we hope to have a lively discussion. The floor is open for any questions that you may have, and I will use Chairman's privileges to pose the first question.
Dr. Thomas?
Yes, Dr. Unicole?
Yeah, sorry, I want to make sure if Dr. Castillo is with us in the panel list. I'm trying to locate his name, I could not find.
Okay, he may have been bumped, or maybe there is technical difficulty there, I don't know.
Dr. Boris, by chance, are you with us?
No, he has left.
Oh, okay. All
right.
right.
I think zero is still gone.
Okay, duly noted. All right, so we will start with our other panelists. And my first question is for Professor Ramshabag. Dr. Arjun Srinivasan, who was Assistant Director of the CDC at the time, was quoted as saying, "We've reached the end of antibiotics, period." And I know, Professor, you had spoken to us about antimicrobial drug development. Can you comment on whether you think there's something to be learned from beta hemolytic streptococci, who have remained uniformly susceptible to penicillin, that could inform how we look for novel therapies? Prof?
Was that question for the Sadesh Ramsberg?
Yes, it was, Prof.
He has left the panel. And then
Okay. So, I'm so sorry, colleagues. We've lost Professor.
He's with us, but he's
okay. All right. Okay, then.
Okay. He's here now.
He's here now. Okay.
Yeah. All right, go ahead.
Right. Professor Ramsabag, I'm going to repeat the question. Dr. Arjun Srinivasan had been quoted as being saying that, we have reached the end of antibiotics, period. And I wondered whether you could comment on whether there is something to be learned from group A streptococci that could inform how we look for novel therapies. Prof?
Yes, sorry. I was in the general room and I was now transferring to the panelist room, so I didn't get the question correctly.
Okay, do you want me to repeat it again? Yes, I could. Yes. Okay, no problem. So I was saying that Professor Dr. Srinivasan had been quoted from the CDC as saying that we have reached the end of antibiotics, period. And so I wondered whether you could comment on whether you think there was something that could be learned from beta hemolytic strep, who have remained uniformly susceptible to penicillin, that could inform how we look at novel therapies.
Yes, this is very, very interesting. So I think we need to really understand the evolution of these antibiotics and antimicrobial resistance. And the idea here is to try to be one step of the resistant mechanism, because there will always be resistance coming into the clinical isolates. That is almost a surety. So the idea is we have to go and look at naturally occurring processes. That is in my opinion. So for instance, at one point, there was a movement away from natural product based antimicrobials to more synthetic and computational based molecules. But certainly, I don't think we as humans, with all the technologies that we have, can really be a substitute for nature. Nature obviously would have had billions of years to evolve these mechanisms. So once you have the antibiotic resistance, or once you have use of antibiotics and you have antibiotic resistance, there will be some mechanism involved that will counter the mechanism, the resistance mechanism as well. So this is why I strongly believe that nature has solutions. We have to go and systematically look for it, and obviously apply modern tools of chemical modifications and so on until certainly I think we will have successes. Successes may not be continuous. We may have to go back from time to time, but I think that might be the option that we have.
Thank you so much, Professor. And we know that the first solution did come from nature. So hopefully we'll find something sustainable, yes, and you'll continue to find solutions. Thank you. And I just want to remind our audience that you can post questions in the Q&A box. So if you have any questions for any of our panelists, please feel free to post them now. My next question is for Dr. Reynolds-Campbell. Dr. Reynolds-Campbell, I know, has expertise in mycology, and she has already been introduced as one of our chairpersons. Dr. Reynolds-Campbell, I wondered whether you could comment on whether you think enough is being done in regards to surveillance for fungal resistance and the significance. Can you comment also on the significance of fungal resistance emerging now and being seen in certain fungal pathogens, please?
Okay, thank you for that question. I definitely do not think that enough is being done in regards to identifying resistance in our fungal pathogens. I do believe that sometimes we kind of forget that they're there until they become a problem. So a lot of labs may not even go through the appropriate steps to completely identify the organisms. For example, some labs will only say Candida albicans versus yeast not Candida albicans. And we know that there is intrinsic resistance in some strains, as well as developing resistance over time with continued use of fluconazole in some of your Candida albicans strains. Not only that, you have organisms like Candida auris, which has been popping its head up in several locations, and it's one of the few fungi that you actually have to institute infection prevention and control measures for. Now, if you're not searching for that organism, you won't know you have it. And using many of the traditional mechanisms that we have for identification of Candida species, we may actually miss it. You would have to use measures like PCR or a MALDI-TOF to appropriately identify this organism. And then not to mention even our Aspergillus species. Sometimes they're not appropriately identified to the species level, and varying species will have varying levels of resistance, whether intrinsically or obtained over time, to a lot of the agents, your azoles, your echinocandins. Some of them have reduced susceptibility to your echinocandins. So I definitely think it's something that we need to look into. Persons are living longer, more persons are exposed to immunosuppressive agents over time, more persons are now requiring transplants. And all of these issues will put persons at increased risk. Persons are in hospital, for example, now with COVID-19, and they have increased use of antibacterial agents, which will actually potentiate the growth of fungal pathogens. So if we're not paying attention to this, then it might just be the fungus that takes our patients out. So I do believe that we need to do more. It's something that needs to be ongoing. More research needs to be done. Just in the same way we do our antibiograms, we need to know what it is, what's the susceptibility pattern like for the strains within our region. And then again, we talk about the fact that people travel a lot. In fact, we had a scare before where the patient came with Candida auris, but he knew he had it, he informed the hospital, and as such, he was put into isolation. But with travel, in a day, in a few hours, you can have something right there in your institution that is highly resistant. So it's definitely something that we need to look into. Over.
Thank you so much. That was a very comprehensive response, and hopefully we'll be able to do more in that area. I'd like to now move to Dr. Nicholson. Dr. Nicholson taught me a lot about antibiotic resistance, and I'm sure many of us here, and she does a lot of work in the area of infection control. And so, Dr. Nicholson, my question for you is as follows. Can you discuss training opportunities available in the area of infection prevention and control? It is a rapidly developing discipline with a lot of new data emerging on various aspects of the discipline that informs practice. I believe it's an important opportunity that should be created in terms of just having opportunities for training and sharing on the studies that are being emerged and new practices that are being recommended and so on. So can you comment on this, Dr. Nicholson?
Thank you so much, Dr. Tom Rodriguez. Good afternoon, everyone, again. Yes, I do have an interest in infection prevention and control. And I think it's an area that we probably don't focus on as much as we should in the Caribbean. With the high rates of resistance that we're seeing in our isolates, that makes it even more important for us to go to the other end of the picture and to put in place practices, to have well-developed guidelines, to make sure that they are enforced, and even better to have surveillance systems so that each healthcare setting knows the challenges that it is facing so that they can counteract those challenges appropriately. And I'm going into all of that to answer your question and to say that we have just introduced a postgraduate diploma in infection and prevention control in the healthcare setting. That's actually just started now. It's been approved. It was approved by the University of the West Indies, and it's a 10-month course. And we basically have a wide panel of presenters, persons who are top, really at the top of the game. And we really are privileged to have them sharing with us, along with our local presenters. In that course, we look at a wide range of infection control challenges. And thus far, I must say that I am enjoying directing the program. I really am. We have about 15 candidates in the program at this point, and they are drawn from Barbados, Jamaica, Nevis, St. Lucia, Cayman Islands. I think that's it. But we have a group of very enthusiastic healthcare workers, and that augurs well for the Caribbean. But I'm really glad for this opportunity to put it out there to say that it's there. It's, you can have a look at the schedule, the program if you want to, but we took into consideration the challenges that we face in this region, and the program is geared towards producing well-rounded infection control practitioners. And I think that the more we do this in different areas, I know that Trinidad has a certificate program, and the more that we can train our persons, because so much has been learned. The whole discipline of infection prevention and control just kind of mushroomed out at the beginning of the 21st century. And so much information has been gained, and the whole slant now is evidence-based. So you do your research, you produce the evidence, and then you challenge and change behavior. And I would love to see all of us moving in that direction, so persons don't have reasons to not follow guidelines because they understand that these guidelines are based on evidence coming from your institution, etc.
Thank you. Thank you so much, Dr. Nicholson. So there you have it. And again, I would like to encourage our audience to pose any questions that you would like to ask in the Q&A section. And if anybody is interested in learning more about the IPC training opportunities, I'm sure we can make available information about how you can contact Dr. Nicholson. All right, and now I'll move to Prof. Jaya. Professor Jaya, I wonder whether you could comment on what you think is the most important next step in the fight against antimicrobial resistance within the region and globally. And after Prof. Jaya comments on this, I welcome other panelists who want to weigh in to comment as well. Professor Jaya? Professor Jaya, are you able to hear us? I'm not sure if you're having any technical difficulties. All right, we're not getting anything from Professor Jaya at the moment. So I wonder whether any of our other panelists want to comment on that question. What do you guys think is the most important next step in the fight against antimicrobial resistance, both regionally and globally?
Dr. Thomas, I think Dr. Lewis is raised his hand.
Oh, okay. All right. Thank you for that, Dr. Unical. While our panelists think on those questions, or that particular question, sorry, I will invite, hold on a minute. My colleague who has their hand up, you can go ahead if you have a question. To find who it is. But if you have a question, feel free to go ahead and open your mic and you can ask the question, or you can post it in the chat. While we wait on that, we have some questions from our audience. They would love for our panelists to comment on surveillance of antibiotic resistance in the current situation of the pandemic. And I don't know if Dr. Nagasar is still with us, if he could weigh in on this question as well. He's not one of our formal panelists, but he did present to us on surveillance. So a question from an attendee is whether our panelists can comment on surveillance of antibiotic resistance in the current situation of the pandemic. Perhaps Dr. Nicholson, I don't know if you want to start and to say whether you think enough is being done in this area, or has attention been shifted to focus more on the pandemic?
Yes, well, I certainly have seen publications coming out from other countries concerning this, but locally, we really have been stretched just trying to cope with COVID. And I can't tell you that a lot of antibiotic surveillance is going on right now, but it is on our radar, and it is something that we don't want to get away too much from us. So it is something that we plan to do as soon as possible. And of course, we are keeping our eyes open for, noticeable trends. But in terms of that systematic monitoring, I think we're a little behind on that at this point in time.
Okay, thank you. And Dr. Nagasari, do you want to add anything? Or has it been said? Okay.
Yeah, so Dr. Nicholson's comment was quite informative. In addition, I would say that surveillance should continue if it's not already going on, because even though some studies would say there's not a lot of co-infection, there are instances of resistance developing within the pandemic, and knowledge, attitudes, and practices surveys maybe also are showing, because I am doing one right now, that there's more use of antibiotics, and dispensing of antibiotics during the pandemic. Because unfortunately, when people get these viral infections, they still get over-the-counter antibiotics. And so yes, surveillance is important, but to answer the question before, I think one of the things that needs to be done is not just developing policies, making acts, but enforcing what already exists. Because you might have acts existing, but they're not being enforced, right? So that would be one of the to answer the previous question that was posed to Dr. Jaya. One of the things that needs to be done is enforcement of frameworks, like legal frameworks, policies, and so on, and not just having them, but enforcing them and then building on them. All right, so thank you.
Thank you so much for that, Dr. Nagasar. I noticed that Dr. Lewis has her hand up. I'm not sure, Dr. Unicol, if you're able to make her a panelist so that she can just open her mic and ask her question. I'm not seeing anything coming across in the Q&A box.
Yeah. Yes, Dr. Thomas, I gave credentials of panelist to Dr. Lewis.
Okay, so Dr. Lewis, as soon as you're able to accept that, the prompting, we will be able to be on the panelist side and we'll be able to take your question. All right, are there any other questions from anybody else? And while we wait on that, I'm not sure if Prof. Jai is able to comment now on what he thinks are our next best steps in the fight. Thank you so much for your comment, Dr. Nagasar, in terms of putting in strategies for enforcement. And I agree with you. I think that's very, very important. Because compliance is so important. Professor Jaya?
I think he must be having some technical problems. He's unable to switch on his video, audio and video.
Right. All right. Okay. Will any of our other panelists, do they care to offer a response to the question? And somebody coming in?
Yeah.
Okay, go ahead, Professor Ramstabag. Thank you so much.
Sorry, what was the question?
Okay, sure, I'll repeat it. So I wanted a comment on what you thought was the most important next step in the fight against AMR within the region and globally. And Dr. Nagasar had already commented and said that he thought enforcement measures would be an important next step. And I'd just love to hear your thoughts as well.
Okay, well, certainly I will support what Dr. Nagasar said about policies and monitoring and so on. I'm not sure of what is the level of adoption and implementation of antibiotic stewardships in this region. I think this needs to be considered seriously as well as part of the management strategy for effective management of resistant infections. But I'm more from the environmental side, but I can also tell you we have a lot of problem with respect to pollution. That also has to be managed because there is constant opportunities for infections or antibiotic resistance to move from environmental organisms to pathogens. But if we look, for instance, at the level of pollution in this region, I know in Trinidad, a large proportion of wastewater treatment plants, for instance, are not working properly. You have untreated wastewater from farms going straight into the rivers. And then this water is now being used for irrigating crops. And if we know food safety practices at homes, not everyone will be properly treating their vegetables, for instance. They might just pass it under the water and then consume things like lettuce. And this could be an important source of infection from these organisms that would have been exposed to the environment, and you can have transfer of resistance. And then, the cycle can continue. I think that also has to be considered in the mix of managing antibiotic resistance infections.
Okay, thank you so much. And so at this point, I'll just ask each panelist to give one final comment. If I get no further questions at the end of their comments, we're going to have to close this section. So I would ask perhaps Dr. Nicholson to start, and then Dr. Reynolds Campbell, and then Professor Ramstabag, please, in that order. Thank you.
Okay, well, Dr. Toms, I just have some random thoughts running through my head at this point in time. I know how difficult it is to get all the different arms that should be involved in fighting antimicrobial resistance together, but how absolutely essential it is. We can't keep the persons who are involved in human health separate from animal health, because antibiotic resistance will just keep going up. So the persons in human health, the persons in animal health, in the environment, as was mentioned a while ago, and so many other areas really do need to come together. And in some cases, for example, in Jamaica, and I can speak about what's happening here, and I'd love to hear about what's happening in other areas. We actually started, we have a very robust group working together. We have plans, we've been following the guidelines and trying to meet deadlines in terms of an international collaboration. But it's not easy. It really isn't easy to get all the arms moving together. I don't know how much easier it would be made if we had like a Caribbean movement pushing that. In the CACM, we've tried that from time to time, and I think we need to still continue to encourage it as much as possible. I think about areas, Dr. Toms Rodriguez, like education, educating the public. I will share a gratifying experience that I had in the last week or so. It was my time to give a lecture on antibiotic resistance to the first-year medical students, which I did. And say I did this on Monday. By Wednesday, I had a call from one of the medical students who said that they were really quite disturbed at what they had heard, and they wanted to know what they could do to be a part of the fight against antibiotic resistance. No, I was really gratified by that. And I, talked about education. I talked about, sharing any opportunities that came up. For example, World Antibiotic Awareness Week is coming up. I told them about it and so on. But to my surprise, by the Friday, I was invited again to speak to a group of them, not just medical students, no, but other healthcare professionals who share that first year set of classes. They had organized a forum. There were 100 students waiting to hear more about antibiotic resistance. That made my week, my day, my month. And they asked questions. They were enthusiastic. They didn't leave it there. They recognized that the fight is theirs, because when they graduate, they will be in the problem. They will have the problem of not having appropriate antibiotics unless something dramatic happens. And so they're prepared. They, hashtag save the antibiotics is what they are going forward with. And if this could be generated across the society, I am sure that the change that we're looking for would happen. And if it could be generated across the region, I'm sure that the change that we're looking for would happen. So there's hope. I share that to say there's hope, and that we must not ease up on the fight. It's important. It's important for the next generation. It's important for now. And so where the hands might hang down because of how slow progress can be and how long it takes to change behavior and to penetrate cultural barriers in order to have attitudes towards antibiotic usage changed, it can be done. We can help each other, and going forward, we believe that we can make a difference. We just have to persevere and consistently put our best efforts forward.
Thank you so much. Thank you so much, Dr. Nicholson. Well said. And I'll now ask Dr. Reynolds Campbell to also share with us her final thoughts on the way forward.
Well, I definitely agree with Dr. Nicholson. I think a lot of what is needed is further collaboration amongst the countries in our region. We all have similar backgrounds, similar situations in our institutions, similar needs. So if we help each other, then I think we'll have a better understanding of what's happening in the region and better be able to help each other with whatever it is that we may need to have in place to give our patients the best outcome or to slow antimicrobial resistance in general. I think also an increase in training. There are several courses that may go around. We should share and share alike so that we're all equipped to better, be able to handle the problem at hand. And Dr. Nicholson, thank you for the course that you have created. I think more needs to be done in that regard. More students need to come on board next time around. And if we can increase what goes out that persons can log into, and the virtual background that the pandemic has forced us to take has shown us that we can stay wherever we are and participate in functions just like we're doing today. So therefore training shouldn't be a problem now. It shouldn't be that students are unable to reach a certain location and as such they can't participate. No, we realize that it can be done and it should be done, and if so, we can actually improve the general output that all our countries in the region are able to put forward.
Thank you so much, Dr. Reynolds Campbell. Together, we are indeed stronger. And it's quite timely, your comment is timely, because we have a comment/question from one of our audience members and presenters. And it is that he says, we're in the age, and this is from Carlos. He says, we're in the age of technology, yet bacteriology hasn't exactly gotten faster from sample to diagnosis without sacrificing accuracy. Does the panel think that our next step is making the industry more unified to have access to shared resources to expand? And I think you would agree, Dr. Reynolds Campbell, and certainly we know there's a need for more point of care tests, more accurate point of care tests, and so on. So Carlos, I think that they would agree with you. All right, I don't know if anybody else wants to add to that.
Well,
Sure.
Dr.
Sure.
I just wanted to draw attention to our Molotov. Is this an appropriate time, Dr. Thomas Rodriguez?
Yes, it is. Go right ahead.
No, I just want to say that we recently acquired a new member of our microbiology family, mass spectrometer, which means that we can, know the identity of an organism in a much shorter period of time. Of course, there has to be some growth, but it doesn't have to be a lot, just even a film on the plate, and the machine can identify the organism in no time. So we're moving on. I want to share a little bit about the background of that too. I had gone to Mount Sinai Hospital in Canada, and of course was impressed by what that added to patient management. And so when the head of that lab was coming to our lab, I asked him to come prepared to do a presentation to our CEO. And so he came and he made a presentation to the CEO and the operations manager. And by the time he was finished, the CEO said, "I want one of that." And that was that. So sometimes we who know what's out there have to bring it to the persons who make decisions and the persons who can probably source finances to help us. Sometimes, well, certainly I would have heard the cost of that machine and said, no way can we afford that. But we pushed past that hesitation, and the rest is history. I think we got that machine in a relatively short period of time, and we have been using it. Members of the bacteriology staff, they are so delighted. Of course, reagents are not expensive. The machine is expensive, but reagents are relatively cheap. So you invest in the machine and you go along with the reagents as you can. And that has made a difference. I'm not saying that, you know, it's the end of the world, but it certainly has made the staff feel as if they're contributing more, made life a little easier, and helped us in times when we want to know what that organism is so we can, you know, intervene as soon as possible. I just share that as another experience and, you know, something that will encourage us to not give up, but to keep pressing in. Thanks, Dr. Rodriguez.
Thank you so much, Dr. Nicholson. The MALDI-TOF is indeed great and rapid. And for some samples, you can go direct from sample and in minutes. Yes, indeed, we do have a result. And it's already able to rapidly detect some resistance mechanisms, and they hope to be able to expand susceptibility testing on the platform. So I underscore what Dr. Nicholson has said about the MALDI being a novel sort of piece of tech instrument that we're using now, and it is definitely helpful. And hopefully we will see it being put to more use in the region. All right, and so we leave final comments for Prof. Jaya on the way forward. Prof. Jaya?
Not sure, Prof. Jaya, yeah.
I think he must be having some technical issues.
Okay, no problem.
Yeah.
Oh, he said coming in a second.
Oh,
all right, so we will wait for that. And as we give Prof. Jaya just a few minutes to share with us his final comments, I'm going to move to the award announcements. And if you just allow me to share my screen, Prof. Jaya, you can just let me know when you are ready. Okay, can you just confirm that you are able to see my screen?
Yes, Dr. Thomas, you can see.
Okay, yeah, wonderful.
Now Professor Jaya is with us, so you can repeat.
Okay, Professor Jaya, you can go ahead. Professor Jaya?
Hello?
Yes,
hello?
Professor Jaya.
Good afternoon. Yeah, could you hear me?
Yes, we can hear you.
Okay. Sorry about that. You know, my mic was not working. That's why I just, you know, I put a different mic. Yeah. Yes, thank you very much. Thank you for having me. And I had been in and out since this morning. I just, I was there since morning, you know, with the start of the session. And I was observing most of the talks, and I'm really enjoying. So thank you very much, and everything is going fine. So I was not able to vote for the speakers. You know, somehow the polling option has gone. But anyway, so now the session is continuing. So I'm here to listen to you all. So please go ahead. Yeah, thank you.
Thank you, Professor Jaya. So
Yeah.
I just wanted you to just say your final sentence on antibiotic resistance, anything that you want to leave with us as we
yes.
consider the way forward.
Yes, certainly. You know, much has been said, and so this is one of the most serious global issues. And even though we are sitting in a region which is in between two different continents, you know, we are feeling the brunt of it, and we are seeing how this is becoming a serious issue, and as one of the primary health hazards. And you know, this type of conferences, you know, or the symposia is a place where we have to you know, look at the perspective, how things are happening here, and how worse it is. And the next question is how we are going to manage, and how we are managing now, and what is the future. So I think in that way, all these talks as well as the deliberations are going to be helpful. I hope to hear more from rest of the people, so you know what is a way forward. But of course, you know, we do have a plan. You know, the policies were already made some time ago. So only thing is we have to be very consistent in our action, and particularly using all the tools available, not just simply relying on those things that are being classically used all the time, but just go in for other updated and upgraded methods of testing, as well as monitoring, also constant monitoring. It's not just simply looking at the clinical specimens and then making our you know, making a case or whatever, but this requires a thorough and continuous monitoring, and that particular area we are still kind of a little bit behind. So we need to have a systematic method of monitoring, and that is a prerequisite for management. So management comes, it's not just an overnight activity, but we need to have it should be a multi-pronged strategy, and this particular aspect has been well touched upon by some of the speakers, and I'm happy to hear that. Yeah, thank you.
Thank you so much, Professor Jaya. A multidisciplinary approach and using multiple strategies. I couldn't agree with you more.
Thank you.
So that, thank you. That brings us to the end of our panel discussion, and we thank you, the audience, for participating and for staying with us to this point. We now get to the exciting point of the award announcement, and this is for the best abstract presentation. The prize that will be presented is the ASM award for best abstract presentation at this conference, and the winner will be given free membership to ASM. And so if you just allow me a few minutes to share with you a little bit about the ASM, I will do that, and then I will announce the winner. Full disclosure, I did not judge because I had a student who was presenting. All right, I'm hoping that everybody is able to see my screen. Can you say if you're able to see my screen?
Yes, Dr. Thomas, we can see.
Wonderful. All right, and so the ASM sponsors many awards yearly, including prizes like today's award for the best abstract presentation. And we're happy that they are able to continue to sponsor this award. Like the CACM, there are many benefits to membership. And I do hope that those of you in the audience who you know, are not yet members will consider joining the ASM as well as the Caribbean Association of Microbiology. You can contact any one of us here if you want to be a member of the CACM. You know, our email address is cacmjamaica@gmail.com. And you can use this link shown here, this URL, this address, to find more about how you can find more information about how you can join the ASM. There are several categories of membership listed here, ranging from a cost of $35 to $195 annually. And there is a global outreach program for scientists from resource-constrained settings, and they get free membership, and they get access to all the online ASM journals at no cost. The ASM has several journals yearly, and I've listed here this year's set of conferences, and some of them have gone already, but there's some still to come. So please be on the lookout for that. It's an opportunity to get your work shared further and to broaden your horizons in terms of collaboration and so on. And so please visit www.asm.org for more information, or you can contact me. And so without further ado, I want to announce today's winner. And before I announce the winner, I'd like to say who the runner-up is. So I want to also say that all four presenters who were presenting abstracts that were being considered for grading did very well. Or I should just say all of our abstract presenters did well. Our runner-up presenter is Carlos Ramprasad. Congratulations, Carlos. He presented on urinary tract infections among patients attending Chaguanas District Health Facility. And our overall winner, who also got the popular vote done by polling, is Mr. Stephen Stone. So congratulations, Mr. Stone. You are the winner of the ASM Prize for Best Abstract Presentation, and you can contact me about how you can redeem your prize. Thanks to everyone for listening to this point. I will now hand over to Dr. Unicol, our conference chairman, and congratulate him for an excellent symposium. Dr. Unicol.
Thank you, Dr. Thomas, for your wonderful job. Much appreciated. It went on very well, the panel discussion. And also I thank once again for all panel members for taking part in this discussion. Along with that, I extend my heartfelt congratulations to the winners. Keep doing, keep rocking, continue to do research, keep contributing to the society. Thanks for winning, and congratulations once again for your winning in this conference. Having said that, now dear all, we are at the last stage of our conference. I know you all love this event, right? Because I know since morning you must be tired and you must be waiting to conclude. To conclude this program, I would like to request Dr. Ariana Brown Jordan to extend our vote of thanks for all the participants, invitees, guests, and panel members. Before that, I would like to introduce Dr. Ariane Brown Jordan. Dr. Ariane Brown Jordan is having a PhD in veterinary microbiology and is an early career scientist working in the field of public health and laboratory diagnostics. Specifically, she had a strong background in diagnostics of viral infectious agents of veterinary and medical importance, as well as management of laboratory and molecular testing services. She has worked specifically as a member of the team for National HIV/AIDS Health Program and has supported other various areas of public health importance. Currently, Dr. Brown plays a major role in supporting the national SARS-CoV-2 response at the University of the West Indies, St. Augustine, through the Pan American Health Organization. Currently, Dr. Brown is serving as also secretary for this Caribbean Association of Clinical Microbiologists in that chapter. Dr. Brown, I invite you to join for extending our vote of thanks to all the participants.
Thank you, Dr. Unicol. So I know a couple of attendees have dropped off, but I wanted to thank the attendees for their attention today, coming on board. And I really hope that the knowledge gained would translate into some growth on understanding, exploration, and of course, most importantly, impact at the place of work and within your networks. Dr. Mishra, we appreciate your sharing on the lead up to drug resistance and how we can take valuable steps, each and every one of us, to reduce the incidence. Dr. Thakkar, thank you for sharing on practical ways to address the infections in the surgical setting. Updates and reminders are always useful for our body. Dr. Nzuri, contributions have indeed been well received and very timely. the effects of SARS-CoV-2 on kidney function and the ripple effect on patients. It was excellently delivered, and we are glad to have heard the details behind the increased risk of to clients with chronic kidney disease and the poorer responses to vaccination efforts within that group. Dr. Ramsabag, we are so excited to have heard of the excellent research being done at the UWI St. Augustine within your unit. And we really hope that the exploration of these adjuvants will continue to be rewarding for you and your team. Dr. Castillo, thank you for your contributions and your views on antimicrobial resistance in the healthcare settings. Of course, I'd also like to thank the presenters within the judged portion of the symposium, Mr. Stone, and congratulations on their award. Thank you, Mr. Bull, Mr. Rampasad, as well as Mr. Hohenkirk. I'd like to thank Dr. Nagasa, and personally, I want to thank you for your continued work and contribution. I would say it's the selfless support that you continue to give to Trinidad and Tobago, and I really wish you well in your endeavors. I'd like to thank the panelists who were present. Well, thank you for chairing the panel discussion, Dr. Thomas Rodriguez, and of course, Prof. Ramsabag, Dr. Reynolds Campbell, Dr. Nicholson, Prof. Jaya, thank you again. I also want to make mention of our sponsors for today's session, which was so excellently pulled off. I would like to thank MSD, Twin Medicines, as well as Twin Pharmacy, Life Care, and Dr. Subash. And of course, I would like to extend heartfelt thanks to Dr. Unicol. I would like to say he almost single-handedly pulled this off on his own, because we've had a recent transition to the executive, newer members on the executive in the Trinidad chapter. So a lot of us are novices with regards to what was done today. And he did quite a bit of work on the background to pull this off today, and it was so beautifully presented. As well, Dr. Packer, thank you for your continued hard work and support for this Trinidad chapter of CACM. Again, thank you to everyone who has attended, and we really hope that we see some, movement within the CACM to bring some new membership, of course, to communicate as well about the antimicrobial drug resistance as well to the population, as Dr. Nichols had expressed what had happened in Jamaica with just one lecture that she did. So it would be nice to see similar things happening across the Caribbean. So thank you again, and all the best.
Thank you, Dr. Ariana Brown. And once again, I extend my thanks to all participants, panelists, chairs, and one and all from India, Nigeria, Latin America, Caribbean countries, as well as Trinidad and Tobago. Now I declare the program is officially being closed. Thank you very much for being with us. Enjoy your rest of the day and have a good evening. Thank you.